Welcome to the Healthiest Tech Talks, where we're talking about some of the biggest challenges facing healthcare organizations today and how technology can transform the way we work so that patients receive better care. I'm your host, Natalie Tollefson, Senior Director of Customer Success at Optimum Healthcare IT. Let's dive in. All right. Well, welcome, everybody. Thank you so much for joining us today. This is our 8th episode of Healthy as Tech. And today we are joined by two very exciting guests. I've been so much anticipating this conversation. We're going to be talking about a topic that has been driving conversations across every industry, including healthcare, and that is AI. So before we dive in, I'd like to introduce our esteemed guest. First, we have here Aaron Miri. Aaron is the Senior Vice President and Chief Digital and Information Officer at Baptist Health Jacksonville. Since 2021, Baptist Health is Florida's largest, most preferred health system for more than 25 years, with 6 main hospitals and more than 14,000 team members. And Aaron has more than 20 years of healthcare and technology experience himself and serves as a thought leader on digital strategy, not only at Baptist Health, but across the entire healthcare community. And he's also nationally recognized by Becker's Hospital Review on their list of 2024's CIOs to know, and holds a seat on Chime's Board of Trustees. So thank you so much for being here, Aaron. Maybe you can share just a quick, interesting fact about yourself for our audience to get to know you better.
Sure, Natalie. Thank you. And thanks for everybody listening today. So as Natalie introduced me professionally, but personally, I'll tell you the fun fact of the day is I'm in the final throes of my doctorate, defending actually March 14th. So send good wishes my way, or just candy, chocolate. I love white chocolate the most. And my topic actually is around artificial intelligence and really trying to dive into what are some of those hesitations that clinicians may have when it comes to AI, which today in this talk, we're going to talk about a few of those dimensions and what you can do to combat those.
Well, that couldn't be more perfect. I could not have written that script better myself. Thank you, Aaron. That's perfect. And then we also have Mike Peter with us. Mike is the Chief AI Architect at Thinkgen.ai. Mike's career in AI actually started in 1999 with his first AI startup adventure. And since then, he has been continuing to lead the charge with the ever-evolving world of AI, including having spent over 6 years as a principal architect at Google in their cloud AI and machine learning business unit. Mike, we are so excited to have you here today as well. What is, I know you happen to be in an interesting place in the world right now. Tell us a little bit about that.
Sure thing. And again, yeah, thanks for being here. And I want to read Aaron's paper. So if you need like an editor, would love to do that. So yeah, Michael Peter, right now, the fun fact about me is I am sitting in the airport in Saudi Arabia, just finished a AI conference on advanced manufacturing and logistics. And then I led an innovation workshop shortly after the talk. There's a ton of interest in the region in AI, a ton of interest sort of across the globe in AI, and everyone's trying to figure out how to tackle it right now. So this couldn't be a better time to have this discussion. Also, if I'm on mute for an extended period of time, it's because they're probably announcing my flight, but I'm going to stick it out and stay with you all.
We will try to end on time so you don't miss your flight out of Saudi Arabia. Thank you, Mike, for being here. So let me kind of get us introduced to the topic and how we're going to approach this conversation today. If you are a healthcare CIO or a technology leader in healthcare, you probably have some mixed feelings when it comes to the topic of AI, I would imagine. I would imagine that you have maybe some excitement and eagerness to want to lean into these advanced technologies, especially as you're seeing others use it within your network and making incredible advances within their organizations and their industries. You're probably getting some pressure from stakeholders and from boards to get started, to build a strategy. but you're also being held accountable to do that responsibly and in a way that not only saves your organization money and resources, but is also fully compliant with HIPAA and all of the other, regulations that especially healthcare organizations are held to. And I imagine that you're probably pretty overwhelmed by all of the options, the hundreds, if not thousands, of different AI products and solutions. And, it is just the buzzword of the century at this point. And how do you sift through the noise? And how do you understand what's right for your organization and how to make sure you're setting your organization up to be successful, especially in healthcare where patient lives are at risk? So that's what we're going to really try to tackle today. It's a lot to navigate, but thankfully we have two experts that have done it here. And if you're wondering where to get started, you're not alone, and you're in the right place. So we are going to dive into 3 practical steps for healthcare technology leaders, how to get started with AI. But before we do that, I'd like to hear a little bit from Aaron, because Aaron, at Baptist Health, you've already been using AI and you've implemented it in a number of ways. You have a roadmap, you have a vision for it. And what I'd really like to do is help paint a picture for our audience on what could be. And
Absolutely.
yeah, why don't you go ahead and
Yeah.
share some examples?
Let's go into it. So let's do a little education for a session. So healthcare has been using machine learning and advanced decision support, which is an early form of AI, for quite some time, since really digital records came around. So call it the past 20 years or so, healthcare has been doing a really good job with very upfront, in your face kind of conditions that you would present with to help a clinician diagnose what could be really wrong with Aaron. So these are common conditions like sepsis or other types of clinical quality, bad outcomes that we want to get in front of by looking at numbers of patterns of comorbidities or issues you may be having when you present to an emergency department or wherever, and say your likelihood of having X, Y, and Z is this. Therefore, let's get you on a regimen immediately, right? Whether it's a prophylactic upfront or whether it's something retrospective, depending. So healthcare is not new to AI. What's new with AI are the new types of AI models. You've heard of large language models and small language models and graph models and these other capabilities, because compute and cloud availability has come to a precipice, a tipping point, where we can now access these types of technologies in a way that could not be done historically. It was all on big iron in your data center. So healthcare is now taking to those new capabilities, looking at advanced visualizations and advanced decision support capabilities, aka AI, to tackle even harder problems. So let's talk about some real world things we've done here. So number one, we've alluded to sepsis and fall detections and other things like that. Baptist Health has been doing this for years and years and years and years and years and getting better with the data, right? The more data we collect on a patient, the better we are at spotting what's going on, the faster we can intervene with medication or whatnot and help you get better. So that's a table stakes, mom and apple pie. We have some of the best clinicians in the world, which is why we're the most preferred leader in the region, using technology smartly. What have we been doing, though, now that compute and others are highly available? Let's talk about that. In October of 2022, you saw the big open AI announcements about ChatGPT. Suddenly, you had Google on a race with Bard. You had Facebook with Lambda. You had all these AI large language model agents out there that you can build upon, looking at advanced sort of linguistic humanality type capabilities to say, let me ask this large language model a very general question in English and get an answer back, versus an algorithm running behind the scenes that gives you an output. That really changed the game. For us, we've looked at everything from when it comes to how to respond to our patient inquiries, doing bill estimates, working with our insurance payers to accelerate prior authorization and adjudicate claims, all the way down to a clinical diagnosis to help a physician summarize a very busy patient chart. So what did we do at Baptist Health? We leaned in. We said, where can AI be done smartly and responsibly, as well as within the letter of the law, which let's face it, Natalie, you've kind of alluded to this. HIPAA and others really haven't kept up with the Joneses. So we're having to navigate a very gray area without doing any patient harm. So with that, we've been leading those efforts, looking into these types of problems. And we'll talk more about that today as we go into further detail about how we've really sort of unpacked these items and really steered toward true north.
That's fantastic. And I'm sure that you'll be able to share even more about those use cases as we talk through the practical steps and what it looked like for you to actually roll those out. But I'm curious, if you had to choose something that's aspirational in the future that maybe you're starting to work on, kind of your next vision for AI at Baptist Health, what would that be right now?
Yeah, so three things. Number one, click less, meaning get your hands off the keyboard and off the mouse. It should be voice dictated, should be driven by other types of modalities in the room, maybe LiDAR and others that predict and help you as a clinician get in front of what that issue is. And so you're sitting with the patient more than you are typing on a keyboard. So that's number one. Get away from the keyboard, have AI, whether it's ambient, whether it's large language models, whether it's whatever, being able to work behind the scenes to empower you to be at the bedside and away from a computer. Unfortunately, in today's technology world, there'll never be 100 now, but if we can get to 90, 95%, we're off to the races. That's number one. Number two thing, technology that's at the point of care, meaning I'm not having to look up and look at a screen. I have it right at my face in line with what's going on. So let's talk, okay, patient Aaron, here's what's going on. I think you have a fracture in your arm. Let's look together. Boom, technology right here. So that way you're not taking away from the human aspect of technology. We're trying everything we can to put it at the bedside. Last but not least, data fidelity. And I'm sure Michael will talk about this later on, the importance of accuracy when it comes to outputs of either it's an AI algorithm or any just decision support aid is so important because healthcare is built on the speed of trust. And if I interrupt that trust, any clinician worth their salt will be like, I'm not doing this. I am not going to jeopardize quality when it comes to my patient at all. So we have to make sure we never lose sight of quality assurance and that the outputs that we have from either our AI or data outputs or whatever it may be technology-wise is spot on every single time.
That's fascinating. And I imagine that's a lot of pressure for an IT leader to charge into
just a little bit, just a little bit.
Just maybe a little bit, yeah. To charge into something new and experimental at that point, with all of those expectations from regulatory bodies and from your own organization and the rights of your patients, right? To uphold. And so this is actually a great leeway into our first practical tip, on how to help other healthcare CIOs and technology leaders get started with AI, which is to get your stakeholders on board, right? And so, Aaron, can you talk to us about what that process was like? I know you've been using AI at Baptist Health for a while, but once the generative AI and the new technologies became more prevalent and more complicated, what was that like to get your stakeholders on board and to really drive adoption with some of these newer technologies?
Yeah, great question, Natalie. So I often hear this across my CIO ecosystem of my peers. They don't know where to get started. They don't even know how to engage their organization. They don't even know where to start. Like, what's the first square on the Monopoly board I need to go through? So the reality is start number one. What is the why? What are you trying to solve? And align that around the common things that we do in healthcare and do well. Patient safety, patient quality outcomes, right? Maybe it's good stewardship and financial stewardship. If you're a health system with very, very tight margins, like over half of the health systems in the country, whatever that may be, solve a problem through a straw. Do not try to boil the ocean with AI. What am I going to focus on? Again, choose sepsis, choose fall predictions, choose something right in the alley that I know every single one of you listening that are practitioners are having to work through, right? Every single day. So choose a problem, have a true north. For us, it was patient experience and patient quality. Boom, hit it around the head. That's number one. When everybody can align on the why, now it's about the parameters for expectation and delivery. Set up a series of guidelines. For us, we started with a general framework of we don't want to tell a good idea no. We want to make sure we are able to intake those ideas coming from our frontline nurses and doctors and clinicians and say, what are you trying to solve? What's that why again? Why would we want to do this with AI or other technologies? And then more importantly, where does rubber meet the road? Meaning, what can our patients expect from this, right? What does that patient experience ultimately look like with this in there? So these guidelines and parameters that we establish are very general, right? Don't put, protected health information in a public large language model because it's not protected by HIPAA. Do not do these, common rules of the road. Think of them as speed limits on the highway. We're not saying don't go on the highway. We're saying drive the speed limit, drive on the right side of the road. Don't drive impaired. All the normal stuff that you and I know. We put these common guidelines out there and got a reaction from our clinical staff to say, does this make sense to you? Does this work well with you? We refine it over a series of months, which then translated ultimately into a system policy. Now, the important thing about a policy is that it's not something to go hit somebody over the head with. It's there to protect both you, your clinicians, and your patients. Recall, the laws of the land are not yet there when it comes to artificial intelligence. Example, where's the liability if an AI algorithm says, yep, Aaron, unfortunately, this is cancer, this is a cancerous tumor. Can you sue the AI agent? No, you're going to sue the physician in the hospital. So you've got to come up with parameters that make sense for whatever state you're living in and conform to national uniformity as it stands today with AI regulation. So our policy in the state of Florida was designed around Florida policies as well as national policies to make sure that we're operating within a smart, regulated, responsible framework. Exactly what you said earlier, Natalie. Then it's a process of activation. Having a committee of clinicians led by physicians, led by nurses, supported by IT, compliance, security, ethics, to evaluate these ideas as they come through. Now, here's an important distinction. You can either be a health system that sticks your head in the sand and says, you know what, this AI thing is nothing but a fad. It's going to go away. I could care less. Or you can be a health system that says, you know what, I'm going to embrace my clinical staff. I'm going to listen to their ideas, no matter how right field they may be. But I'm going to find a way to, yes, whatever that may be. Maybe I can't do Star Trek, but can I do something to get us on the path of Star Trek to show partnership and alignment with the clinical community? What has that borne us at Baptist Health Jacksonville? A couple things. Number one, we've seen the clinicians more willing to experiment with us and fail fast and say, hey, you know what? Can we do this? Can we do this? It's like, well, this data model really didn't work. We can try a different way. They're good with that. Number two, we have found ourselves breaching new realms that nobody else has done. And I'll talk more about this later on, solving really complicated, hairy problems that have confounded us. But because of now the power of the new AI models, we can now go tackle those. If I didn't have the trust of the medical staff or the clinical staff, do you think they'd be calling me up saying, hey, let's solve this problem? No. Last but not least, financial performance. Above all else, although we are clinically quality driven, it is a business. You do want to see your overhead expenses drop. You do want to get rid of that administrative burden and the nonsensical things you may be paying for, because now an AI agent can do that. Remember, at the end of the day, our clinicians are generating the revenue for our health system. You make them more productive and happier and get rid of their waste. Guess what? All high tide rises all boats. So we've seen it in numerous dimensions by doing it this way to activate, and we could talk more in the details of this. But at the end of the day, never forget the true north.
Yeah, I mean that's such a great way to describe and thank you for sharing the story of how Baptist Health approached that. But what I'm actually hearing in between the lines are some very reliable foundations to organizational change management for any type of new technology, right? It's defining that problem. What is the thorn in the side of your stakeholders and your users? What's going to make their lives better? What's in it for them? Right. And then bringing and involving those stakeholders, like you mentioned, you established a committee with clinicians in it, and you included compliance, and you included, these other, organizational stakeholders that also had skin in the game.
Right.
And so you described it perfectly, but it really actually speaks to not just AI, but really any type of new technology or process that you're rolling out in your organization. Would you
It does.
agree?
And I don't want to underscore, Natalie, the importance of communication, right? At the end of the day, you as an IT leader, you may not be the CIO, you may be a senior manager. It doesn't matter. You're a leader. It doesn't matter what your title is. It is incumbent on you to explain in plain English, as I always tell my teams, talk to me like I'm 5 years old, in plain English, what is it we're doing and why we're doing it. And more importantly, not only communicate it with the medical staff and the clinical staff, communicate with your executive team, and if you have the privilege to, with your board of directors, because everybody needs to be able to tell the story together.
Great point. Mike, anything you'd add to that?
I'm just gonna I'm gonna plus one what Aaron said. I do want to add, typically with technology, there can be, I can adopt it now, or maybe we'll adopt it later. and you can continue business as usual. With the sea change in the technology that we're seeing right now, and given the impact that it has in terms of the new kinds of problems it can solve or how quickly you can adopt it, the barrier to entry to doing things data sciencey has dropped. There's almost an imperative to take a look at this and start looking at how it's going to affect your organization. There are tons of use cases out there about how it's delivering tremendous value right now. This is not really something you can push away if the purpose of your organization is to solve those problems and to make an impact. And the other part is with those stakeholders, if I go out and investigate something by myself, if I'm inside an organization, I can find something that solves a problem, but it's going to be sort of localized. When I start getting stakeholders on board, when I start getting the entire organization on board, that's when I can start to push the sea change of this can spread across the organization. This can really be something that goes up and down the chain to create a difference. So if you're really looking to make impact, getting those stakeholders on board who can remove obstacles or support you or add resources that you need in order to make this happen. And importantly, anytime there's a transformation or a change that you're making, there's going to be a time where it gets hard and people want to stop. Executive support, stakeholder support can get everybody through that tough time to make sure you get on to the other side of the wall. That's critical.
What I'm hearing is this isn't optional anymore. It's an imperative. And again, patient lives at stake, lots of revenue at stake, costs. I mean, it's just everyone has to figure this out. So I'm just so appreciative that you both are here providing some practical guidance on how to get started with that stakeholder engagement and how important it is to keep communication and to keep those stakeholders engaged, even through the tough times of change.
Right.
Thank you for that. Now, let's talk a little bit more about the nuts and bolts of a strategy. I mean, Aaron, you already spoke to how important it is to have some parameters, right? To develop some policies so that you can remain compliant and have some level of guiding principles to follow. But when it came to building your strategy out and communicating that strategy and executing on it, how did you go about doing that?
Yeah, so number one, seek first to understand. I spent quite some time listening to our clinical staff and our medical staff. What is it that you want, right? What are we trying to solve here? Again, defining those true norths as part of that strategy. So once that's anchored, make sure there's alignment. Everybody agrees, not just an agreement, but you're in alignment. Which direction are we marching in? Okay. So from us, like I told you, patient experience, patient quality came out over and over and over and over again. Okay. Now we're beginning to align strategies around that. So it's a process of looking at, all right, what are the pieces that we own? What are the pieces that we're going to build? What are the pieces we're going to partner with? And starting to coalesce a technology strategy along with a broader engagement strategy across the business. Now we have our platform selections, our technology selections. I know the skill sets of my team. I have a true north. Now we begin to set a framework of, okay, what are we going to do in what order, right? And what is the measured KPIs? The hardest part about all this, believe it or not, it's not the tech. It's the workflow. And how do you actually measure success? That's the hardest part, right? Because just because Aaron, the patient, got better faster doesn't mean the AI algorithm had anything to do with it. So how do I attribute success to technology when you have world-class clinicians at the bedside that probably did magic because they're all magicians in my book. So how do you discern that? And that takes some time to piece that out to go, this metric truly qualifies as an indicator of success. Let me give you a specific example. One of the things we've been tackling hard here at Baptist Health is physician burnout. Trying to, as I said earlier, get them away from being at the computer, having to do this administrative bureaucracy with the coding claims and all the things that you're forced to do as a clinician, right? Physicians did not go to school to be clerks, period. But the US reimbursement and healthcare system has forced them to become clerks. Unacceptable, in my opinion. How do we fix this? We introduced ambient AI listening to be able to take what's being said in a patient room in a conversation, transcribe that automatically using a large language model into the patient record. So the physician's not having to type, I talked to Aaron and he said hi today and he looks better and his arm is not fractured anymore and blah, blah, blah. It should automatically be transcribed, right? And the physician just accepts it. We've been able to show statistically a 20 to 25% reduction in time spent in front of the computer, which is one of our metrics, because of that one AI technology choice. So I can attribute this technology reduced the time of a doc sitting in front of a computer by a quarter of the hour. Beautiful, right? That's the kind of correlation you've got to find. It's not always that straightforward, but if you're doing it right and you're aligning around the right common true norths, you can then begin to develop KPIs which drive that strategy. Back to your question, Natalie. Last but not least, to look at strategy, it's one thing to say we're going to go march this hill. It's another thing to say by when and what's the measure of success. If you look at any kind of KPIs and measurements you put in front of you, in front of AI, right, they should gradually get more and more difficult. So you can see the organization progressing up the hill, or maybe you don't progress. Maybe you fail fast and say, you know what, this ain't working. We're going a different direction, which is completely fine. That organizational appetite as you're building your strategy is very important to define with the executive team and the leadership teams to go, hey, is it okay to fail fast? This is not direct patient care. This is ancillary to patient care. So maybe patient lives aren't at risk. Or is it something that is patient care delivery? In which case there's zero margin for error. You got to get it right every single time. That throttle, you have to truly be careful about it and really qualify and quantify hard up front, which all feeds into the larger narrative and AI strategy.
So that motion of measuring a baseline and then implementing something and measuring the ROI, the change, from that.
Right.
Would you say that that's a muscle that most healthcare leaders that you've talked with already do well? Or would you say that that's something that they need help with?
Great question. I think the muscle memory of internal rate of return or depreciation schedules or normal FP&A kind of stuff that you do on a balance sheet or a P&L, mom and apple pie. That's managerial accounting finance 101. I really generally hope anybody listening knows how to do basic accounting, because that's a finance requirement. What's different is the AI return on investment. That is so nascent and new. It's very difficult to correlate a one-to-one, because I was telling you, it is intertwined. AI lives in the gray space for the most part, right? It's in between Aaron as a physician, hands on the patient, to computer vision of what it's telling me. How do I equate this A to B? It gets difficult, but if you parse it out appropriately and you really are honed in on solving a problem through a straw, that true north, you can oftentimes see what is that key one or two KPIs that you want to go tackle and say, this is a measure of success or a quick indicator of failure, which is okay too.
Got it. Yeah, that's great. Now, I'm going to kind of start to transition and Michael, I'm going to start with you. Now that we've talked about, getting stakeholders on board, defining that North Star, building that strategy, measuring the ROI, Mike, how do you sift? How would a healthcare IT leader know which type of AI model is right for them in any given use case? Can you talk a little bit about what's out there and how to choose the right approach?
Super great question. And we see this a lot, which is customers want to know within an organization, which model should I choose? Foundation models are pretty much neck and neck now, and they change weekly in terms of who has what specific capability. Sorry, I got a little voiceover right now. Can you guys still hear me okay?
We can hear you. Just keep on talking.
Okay. All right. So there's other things that are actually more important than the model, given that for a specific business use case, any of the foundation models would work and are probably more than what you need.
Mm-hmm.
What you really want to look at is, in that potential use case, can I use a small language model, or can I use a foundation model, or do I need to fine tune a foundation model, which are all things you can explore. That's pretty straightforward. The harder part is this: when I'm doing my selection, how do I ensure access and authentication to that model? So if I'm using something that's a consumer-based model, like Google's consumer-facing Gemini or ChatGPT, the security model around that is very different from what I would need from an enterprise perspective, where I need only authorized users. If I'm enabling a capability to, for example, ask about sepsis, I should not also be able to ask about a trip to Italy, right? And then I also need to make sure that I'm doing some extra validation both on the input and the output in terms of fidelity to the question that I asked. What I just talked through was actually 3 or 4 models that you want to put into place, not just one. So for the things that we work on, typically it's a plethora of models that you're applying. And what an organization does is they'll explore like a Claude 3 or a Llama 3 or a GPT or a Gemini and say, okay, this is my big gun for human to machine interaction. If I'm doing things in terms of analyzing all the patient records in terms of who had sepsis, or care, if I'm doing some Medicare reporting, how did that work against CMS's requirements? I don't need that kind of model. I can use a smaller language model to do that analysis, but make sure that I have security around the data, that I have fidelity in terms of whether it's going to hallucinate or not, that I'm able to deploy it easily and integrate it into the rest of my system. Because a lot of the real power isn't just I'm talking directly to the model. It also needs to talk to the other data repositories I have, to the other systems in which I'm involved in. And the easier it is to do that, the faster I can adopt this platform. And the harder that is, the longer that it's going to take for me.
So Aaron, and that's incredible information, Mike. I'm curious from your experience at Baptist Health, when it came to the models, was it like a build or buy for you? How did you decide which models or which products even to procure, and how to train those within your environment?
Yeah, so great question. Number one, I mentioned earlier, there are a lot of models out there, but only a few conform to HIPAA and other requirements that are necessary in healthcare, right? So you have to take a lens of regulatory. What would work in my environment? That's number one, regulatory. Number two, what works in terms of manpower? For us, our first model that we played on was an open AI model, one of the foundation models, just to learn large language models. We started up our own GPT 3.5 farm. We started building out. We actually built Copilot before it became Copilot by Microsoft. We started looking at what are the powers of these, because we wanted to know, first of all, how do you do prompt engineering for real? And then two, how do you start training some of these models with the right data sets? Because as Michael was alluding to, the fidelity data, how clean that data is, right? And how discrete that data is and how trustworthy it is matters. We found a lot of clutter in electronic health record data. So you have to spend some time scrubbing your electronic data, your enterprise data warehouse, so the data makes sense to train that model. So that's number two, is what's worth it? What is the juice worth the squeeze? And three, what are the problems we're trying to tackle, right? Is it some high-end statistical research project that is a QI project we can do internal on a local large language model? Or is it something a lot bigger, like ambient listening and other stuff? But there's products on the shelves that do it really, really good. I'm not going to go build that. Let's just partner with those giants, bring it to Baptist, work with them to tailor the workflow, and let it be a success. So it was a both question for us, Natalie. But we started with drink our own champagne, right? Learn ourselves, then start graduating towards product, build versus buy. Now we're in a hybrid ecosystem where we have both. We have stuff that we've built that is working well. We have stuff that we've deployed that's really working well. And now we're working with developers of being the first in the country at certain other capabilities, because I'm of the mindset, don't just use it, improve it for everybody. So that's how we're going about it here.
Yeah, and just to kind of recap, those are some incredible points. Starting with the regulations, right? Making sure that it's compliant before you even dive in. But then you mentioned the data, and I want to spend just a minute on that. And Mike, I'm going to even ask you if it's not too noisy where you are to talk a little bit about this, because this is something that you and your team at Thinkgen.ai help many customers with across all industries, is preparing that foundation data to use, and be effective with generative AI. Can you talk a little bit about, what advice would you give to a healthcare CIO that is pretty much throwing their hands up, like, how do I even start? Where do I get started with the data?
Yeah, that's a great question. I would say don't tackle the hard stuff first, although you want to start tackling how you're going to get to the hard stuff at the first, but it's not where you put all of your eggs in your basket. If you want to access some, PHI or something like that, eventually that's going to be in your pipeline. So you got to start figuring out how to walk the regulatory stage gates and how you're going to satisfy, all the compliance around that as you go. So you've got like a separate thread, maybe it's 20% of your total capacity, looking at how eventually you're going to get to that data. Because by the time you actually can use it, you got to make sure that you have approval to use it. Where we often recommend people start is, what data can you use right now? Right? What are, doctor's notes? What are other kind of things that or data that is very easy for you to get access to. Could be, support calls, could be other types of things, to do what Aaron just said, to start working on those muscle memories of how you even learn about using that technology. Because when you first take your baby steps, you're doing two things. You're looking to deliver value, and you're looking to work a muscle that eventually you want to be a reflex and you can move very fast. You're going to develop a pattern that you just repeat for similar use cases across the board. So there's often sort of this initial data discovery where you go, what's all the data that you have? And then you start to dump it into a couple buckets. One is, what can we use right away? And let's identify a set of high value use cases. And when I say high value, there's this whole other arching thing around, how do I know that it's valuable? How do I expect my return to be? Because that's when you start to measure KPIs. And then the next piece is, what's in a bucket that we have to access later? How do we start grinding through the organizational and security policies to actually get to that value later? And then start farming it out to teams. And you actually have to put it on kind of a roadmap of, this data is available now. Let's tackle these. This is for later. These use cases are later for those specific use cases as well.
Yeah, Aaron, what would you add to that?
No, I think you hit the nail on the head. And I would say, again, what's important for organizations to understand is that you can't leap from crawling to sprinting, right? You have to go through all the steps in between. And that's difficult because you read in the papers of these phenomenal, fantastical things that people are solving with AI, or they're aspirational, or you have people who are brilliant like Elon Musk building, humanoid robots. So you automatically think in your mind that it's, if you ever read old sci-fi books like Isaac Asimov, right? It's one of my favorite authors, that this is like iRobot or something. No, that's not how this works, right? We're not at artificial general intelligence. We're not even close to Skynet from Terminator. Where we are right now is a learning neural net, right? That neural net, right, functions in terms of iteration and data quality and data fidelity. What you feed it's what you get out. There's been so many public stories about bad data that's gone in a trained model, and the output is horrific, right? You've seen Facebook and others publicize like, oh my goodness, this data was terrible. We took from like the internet, public web, full of garbage and hatred, and our large language model started spewing hatred because that's what you trained it on.
Wow.
So you have to look at this and understand you're going to crawl, then walk, then jog, then run, then sprint. And that's difficult for organizations to understand. But at the end of the day, the crawling part is all about the data. And if you can't crawl, you're sure as heck not going to be able to sprint.
That's great advice. I think it's so important, whether it's AI or any other innovative technology or solution, to follow that roadmap. I mean, as Optimum, in the digital transformation space and implementing major enterprise platforms like ServiceNow, that's something we tell our customers every day. You can't just jump straight to fly. You got to start with crawl, walk, run. And so it's good to hear the continuity of those themes and that wisdom come into this conversation as well. And thankfully, there are organizations and experts out there that can help healthcare organizations follow that path that's right for them. So fantastic. Thank you so much for sharing all of that.
Sure.
Just a quick recap of the 3 practical steps. And there's so much within each one, but number 1, get your stakeholders on board, right? And Aaron mentioned setting that North Star, defining the problem that you're wanting to solve, and involving those stakeholders, including those clinicians, in those governance committees, and setting those parameters. Number 2, build your strategy, starting with compliance. Seeking to understand what those use cases are. What are the different solutions out there? What are the priorities for your organization, and building that crawl, walk, run, fly roadmap. And then number 3, selecting the right AI solutions. And I think a huge part of that, like we talked about, is getting the data ready. And there's a whole slew of things, that's part of the data foundation, and maturing that so that AI can work properly, and so that you can measure the ROI from your AI solutions. But choosing the right solution, having expert opinions and buy-in on that process is also critical. So thank you both so much. I'm going to go ahead and turn it over to Scott and see if we have any questions.
Yes, thank you both. Thank you all for sharing those insights. We do have a question And if anyone else has any additional questions, please do post them in the chat. And this first question is, what is the accuracy for the data model, which is used for the large language model?
So I'll tell you, there is a prevailing philosophy in healthcare that you never want your data model to be more than 80% accurate. Let me explain why. As it stands today, you want to have a little bit of skepticism on the output, especially when it's clinically facing, so that a physician or clinician reviews the results without being trained muscle memory to click accept, send. The last thing you want is for a model to hallucinate or have an issue, and suddenly an erroneous result or whatever comes up, and by muscle memory trained, they click accept. So you never want it to go above 80%. Now, are there future models where that error rate is decreased, thus your fidelity is higher? I'm certain in the future there will be. But as it stands today, it's at 80, no more than 85% threshold is where the accuracy rate needs to be.
That's great. All right. And then another question on another platform that we received here is, how important is it to focus on an industry-specific AI solution versus general models?
Michael, you want to take the first crack at that?
Yeah, I'd say back to what I'm gonna answer, but I'm gonna answer as Aaron. What he said at first, right? You have to experiment with everything. So if there's an industry model, go see what it does for you versus a general model.
Right.
Go see what that general model plus the industry model does versus if I have a set of clean data with a lot of fidelity and I use it to fine tune a large language model. So it's actually tailored not to the industry, but tailored to my use case, tailored to my organization, and figure out which one is the best, because the basically the leader of the pack and the capabilities are advancing at such a fast pace. There, you have to have a constant sort of evaluation framework to understand what the new capabilities are, what's being offered out there, so that you can incorporate them as and when your organization is ready. The edge of technology is not as slow moving as it was before, where you could wait a couple months, a couple years to say, I want to adopt this thing. It's changing so rapidly that you really want an evaluation framework, because you will potentially, and likely, we see customers do this, have pluggable models depending on which one happens to be better at whatever the specific use case is. And different models are better at different things. So that's really the important things. What's my experimentation framework? How am I evaluating the output of the models against my golden set of data and outcomes to make sure that I'm getting the right answers that I need?
Ditto, Michael. And I would also say that for those of you maybe more sophisticated watching this, don't forget, you can have two different large language models checking each other, right? We're doing error checking with large language models. So the output of one model, use a different model with the same data set to see, does it get the same result, and check, right? Quality assurance, we have to get smarter about doing QA when it comes to the output of these models, and don't be afraid to experiment like that. And also to the point of, there are some great partners out there that are leading the way when it comes to AI. Lean into them. If you have a weird thing for the healthcare or your industry, and it's a platform that spans multi-industry, talk to them and say, hey, vendor XYZ, can we be a partner and solve this really complicated, really weird healthcare workflow that your platform was made for everybody, but can it do this? Talk to folks. You'd be amazed at how malleable some of these solutions are that can be tailored for what you're doing without having to recreate the wheel.
Yes, thank you, Aaron. And that's a great segue. If anyone is interested in a great partner, Optimum Healthcare IT, and we collab with Thinkgen.ai, and we are here to help anyone as you're thinking through how AI can be working for your healthcare organization. We do have time for one last question, and I am just going to ask Aaron, did Baptist Health face any kind of challenges around data quality or integration when they were first implementing AI, and how did you address those issues?
Yeah, so every healthcare, not just Baptist Health, every healthcare institution in this country has been plagued with what's called interoperability problems, sharing data between one another, right? The federal government had to pass a law, 21st Century Cures Act, to mandate share your data. If I'm not sharing data, your model is as good as dead, because your comparison set is only what's good within your walls. Now we're able to baseline against national data sets, leveraging national superhighways of data to share data responsibly and securely and make sure that that output is even better. So Baptist Health suffered what everybody else did, which was landlocked EHR ecosystems that did not share data until the federal government mandated it. Credit to the Office of National Coordinator, the ONC, who put in regulation to help that. And now we're able to more discreetly and securely share that data to build even better models of tomorrow.
That's excellent. Thank you, Aaron. Thank you, everyone, for joining. We are going to be having this on Optimum's website shortly. You can also find us on Spotify with all of the previous Healthy as Tech episodes. Aaron, Michael, Natalie, thank you so much. And it really was an enlightening talk, and really appreciate it. And Michael, safe travel to you.
Yep. Thanks. I'm going to dash to the gate. Thanks all.
Thanks,
Aaron,
guys.
thanks a
Have a good
bunch
one.
for your insight.
Bye, everyone. Thanks for joining.
Bye.